Our next speaker in this session is Russell Emeny, who is the Director of NHS IMAS Emergency Care Intensive Support Team. In 2006, he joined the National 18 Weeks Programme and following the successful delivery of the 18-week standards, led the 2009 Emergency Services Review commissioned by SHAs. As an outcome of the review, Russell established ECIST, a team to support local health communities increase the resilience and safety of their emergency care programmes and the delivery of the National Emergency Access Standards. Russell, welcome. We look forward to hearing you.
Thanks very much. Good morning, everybody. Good morning, everybody. Are we all awake still? Okay, great. I think this is a statement of the obvious, really. Last winter and spring showed us that our urgent emergency care system is very fragile. And the question really is, why is that? Performance seems to have been deteriorating in terms of the four-hour standard over the years, and it's becoming increasingly clear that we're running into difficulties. But there have been lots and lots of theories about this. The political theories tend to be around the deficiencies of the previous government, of the out-of-hours contract, and so on. But you can find many other theories. When you talk to Peter Carter of the RCN, he thinks that it's probably down to not enough nurses. When you talk to the College of Emergency Medicine, Jonathan, we could probably do with more emergency care physicians to sort things out. And I read a couple of weeks ago in the Times by a representative from the Royal Society for Prevention of Accidents that with more investment in preventing accidents, we would probably reduce demands on the A&E department. So many theories around this. And I'm going to go through some of the things which I think are causing the fragility of the system. And what this suggests, what I want to suggest to you is it's very complex and quite tricky, and not quite as simple as some people might suggest. Now, the first batch of causes are demographics and finance. Now, we all know about the ageing population and rising life expectancy, so I won't dwell upon that. But there's also a growing population. The sheer numbers of people in the United Kingdom are increasing. The Nuffield Trust, though, in a piece of research, showed that it's actually not really about an increase in the use of EDs by new immigrants, because in fact that group of people tends to use EDs less than the indigenous population and the second generation immigrants. So it's the overall growth in population. Lifestyle with growing obesity, inactivity, and alcohol consumption is a real problem, and as is growing inequality. And of course there are the funding constraints which we're familiar with. Now, the second broad batch of causes is changes to acute care. There's been an 11.8% increase in emergency admissions over the past 5 years, but only about 40% of that is down to the ageing population. So it's something else that's driving admissions into our system. Now, clearly we can do a lot more for patients. Medical technology and knowledge has increased, and I think that's partly reflected in the reducing in-hospital mortality rates that we've had over the years. So that's probably a good thing. There's also, as we described a little bit, as we discussed a little bit earlier, that there appears to be a certain degree of risk aversity which is leading to patients being admitted to hospitals, particularly by less experienced junior doctors. My third batch of causes is what I call the aggregate impact of small effects, small negative effects in this case. There have been lots of different things that have been going on, lots of developments have been going on which have been driving pressure on the NHS. NHS 111. Now, I think overall, most of the evidence suggests that the impact of NHS 111 in driving increased pressure on the emergency pathway is relatively small. However, we do know that non-clinical triage tends to lead to more ambulance conveyances than clinical triage. So there could be a very small impact there. We also know that in some areas, staffing of 111, particularly at weekends, was inadequate, and that led to numbers of patients waiting for callbacks from 111 services. which meant that when they were called back, it was much later in the day. And where those patients were referred on to hospital, there's more likelihood of them being admitted. The reason for that is that patients who rock up in hospitals after about 3, maybe 4 o'clock in the afternoon are much, much more likely to be admitted than those who turn up in the morning. There have also been some national and media messages which have perhaps undermined some of the foundations of our system that we have relied on in the past. The coalition government, when they first came to power, they suggested that the Labour Party's obsession with targets was very problematic. And indeed, they promised to abolish the 4-hour standard altogether. Now, fortunately, they hung on to that. I think rather a lot of us thought that might be a bad idea. But nevertheless, there was an undermining of the message that 4 hours is a good thing. And I'm going to go on to talk about why it's probably not such a bad thing in a little while. Also, there were attacks on out-of-hours medical care. One or two well-publicised scandals has led to lots of media messages and also political messages that out-of-hours primary care is really not up to snuff. And you can understand people becoming nervous about calling out-of-hours and not believing that they are good. Although I think it's true to say that we have got one of the best out-of-hours primary care services in the world. The Francis report also has had some effect, although difficult to measure. Again, Francis suggested that inappropriate obsession with delivering targets was one of the causes of the problems at Mid-Staffordshire. And I think that message may have been heard by many people to suggest once again that targets may adversely affect patient care. A few other issues as well. We know that during the transition, some areas around the country had problems with maintaining managerial grip as people focused on finding new jobs, as people left jobs after many years and relationships that had been formed were fractured. So the transition undoubtedly had some impact on the way in which urgent emergency care was delivered in the United Kingdom. England. The funding issues are well rehearsed. We know that there were funding reductions in social care, but also I think that it's important to understand that where services are asked to make cost improvement savings, what they very often do is they start to erect barriers to referrals. They start to say no where they can. They ask people to resend forms which are not correctly filled in. They'll do everything they can to stem the flood of as they see it, of demand into their services. And indeed, the only two services which really can't do that are A&E and ambulance services. But other parts of the system can. So that can have a very subtle effect on raising the barriers to getting patients out of hospital. And finally, other issues which I think are important for us to consider even now is the impact of scandals such as Winterbourne, where it was quite obvious that the care in nursing homes was very poor. But what that's led to is a great deal of concern by social services and a number of deregistrations of nursing homes. So the number of beds available to discharge patients into has gone down. I suppose the question, though, that you might ask is, well, with all these national effects, how come some hospitals and some systems perform much better than others? I think this is very much down to unwarranted variation and a general failure to adopt good practice systematically across the country. We know that there's a huge amount of variation in health services. For instance, there's a 4-hour variation in the admission rate of people over the age of 65 across the country. We also know that the length of hospital stay, even for patients with the same condition, varies between consultants. It's very difficult to understand why that might be. Weekend mortality is much higher than weekday mortality and so on. So overall, there is a variable application of known good practice, and that drives the variation that we see in the system. So given that we have got a very fragile system, an increasingly fragile system which is under more and more pressure, a gradual rising tide of pressure with a number of waves lapping over us as well, what were the triggers that came along? Admissions were up. In some places they're up to 4%, I think nationally around about 2%. But they were certainly, the number of admissions was greater than the number of attendances at ED, which are rising around about 1.2% and a very gentle rise in type 1 ED attendances, a much greater rise, of course, in attendances at walk-in centres and urgent care centres. There were increased numbers of discharge delays, so it got harder to get patients out of hospital as more patients came into hospital. And we had a very cold March following a relatively mild winter, which obviously triggered strokes, heart attacks, respiratory problems, and so on, and drove that admission increase as well. So overall, there was a combined effect of long-term trends, a failure to systematically implement known good practice, and lots of small stimuli, which have created our rather fragile system, which is very vulnerable to small impacts. Now, the symptoms of that are very familiar to us, and these are the sort of things which we see when we visit hospitals, and we were visiting hospitals all across the winter. Overcrowding in emergency departments was probably the most obvious, and that was almost always down to patients waiting for beds. And indeed, the chief problem that we believe needs to be addressed is the admission pathway. We found that most hospitals, even where they had increased numbers of patients with minor conditions, they could cope with that. What they couldn't cope with was patients waiting for beds, crowding out the cubicles, and making it impossible then to assess the next batch of patients coming in. We found hospitals which are overfull. 100% occupancy was found in many hospitals that we visited. Very long trolley waits, many patients waiting, even up to 23, 24 hours in some cases, and of course not being declared as 12-hour trolley breaches because of the definitions of 12 hours. Depending on how you define a 12-hour trolley wait, it's possible for a patient to wait way over 12 hours. There were outliers across the hospitals as well, patients being in the wrong beds all over the place, and lots of ambulance queuing. In some cases, we found ambulances queuing for 2 or 3 hours to get patients into hospitals. I just want to focus us on one of those issues, crowding in emergency departments, let's say down to patients waiting for beds, and why crowding is a bad thing. People often talk about this as being down to a bad patient experience, which always strikes me as being a little bit nebulous. I think it's rather worse than that. Crowded EDs are very dangerous places. There's a little study by Richardson that found that patient mortality increased by 43% at 10 days where patients were admitted through crowded emergency departments. Now, that's very scary. Another study found that long waits in emergency departments strongly correlated with increased length of stay. And in this particular study, waits of 4 to 8 hours in EDs for admission led to patients having an extra day length of stay, and where they waited over 12 hours, they had more than 2 days excess length of stay. Now, of course, the longer you stay in hospital, the more likely you are to come to harm. Another study, quite well known by Pines and colleagues, found that the administration of IV antibiotics to patients with community-acquired pneumonia was typically delayed in crowded EDs, and in fact that only about 30% of patients would actually get them on time. Now, you'll all know that community-acquired infection can be rather dangerous, and the CURB 65 pneumonia severity score shows just how dangerous it is. If you've got the most severe form of pneumonia, which will put you into an intensive care unit, you've got a very high chance of dying of that. And indeed, even relatively moderate CURB scores put you into a very high risk category. There was also a very interesting cohort study from Canada, which showed that even where patients were seen by doctors and discharged from emergency departments, the longer they waited to be seen, the higher the chance that they actually died within the following 7 days. So even if you are seen in a crowded A&E department, the chances are that the quality of care that you will receive will be inferior to it that you would get if the A&E department was not crowded and was running smoothly. So towards some tactical solutions. And most of these tactical solutions address the problem of patients waiting for admission to admission pathways. We make a mistake if we worry excessively about minors. The big problem of patients who need to be admitted into hospital. The four key ones which we focus on during our travels is encouraging people to tackle avoidable hospitalisation, to focus on home-based rather than bed-based solutions for discharge. Too many hospitals and clinicians feel that it's much safer to discharge patients into residential care or into rehabilitation beds. However, what we have found is that the safest way to discharge a patient is back into their own home, where they can then be assessed to see whether or not they do need to have step-up care beyond that. So those communities which discharge to assess rather than assess to discharge tend to do much better and tend to have shorter length of stay as well. And in fact, we find that there seems to be a correlation between large numbers of community beds and longer length of stay in hospitals. We also encourage people to tackle silo working and gatekeeping along the pathway, to encourage people to say yes to referrals rather than finding ways to say no. But as Simon suggested, I would talk about improving patient flow is the key here, particularly along the pathway, both into and out of hospitals. And I want to make a few remarks about that. Now, we suggest that there are probably 8 broad principles behind great patient flow. Now, I'm not going to go through those, you've got those, but I want to concentrate on just 3. That's early senior review, a focus on discharge, daily senior review, a focus on discharge, and continuity of care. But does daily senior review actually work? In this study, which was done in Liverpool, a team of doctors compared wards which had twice weekly ward rounds, consultant ward rounds, with wards which had twice daily consultant ward rounds. And not surprisingly, I suppose, they found that on those wards that had twice daily consultant ward rounds, length of stay was about half that on the wards that had the more traditional approach. And we certainly find that where we visit hospitals, hospitals that have twice weekly ward round as the norm have much longer length of stay and worse outcomes than those where consultant ward focus is much greater. Continuity of care and regular reviews. Royal College of Physicians in January 2012 suggested that hospitals with 2 or more acute medical unit ward rounds per day on weekdays and where admitting consultants worked in blocks of more than 1 day, they had lower fatality rates. So this is about consultants working for more than 1 day, so the consultant of the day model being replaced by the consultant of many days. There's considerable potential for improvement with changes to the model. They found that only 50% of acute medical units had twice daily ward rounds, and only 9% have consultants on tape for blocks of more than 1 day. So that's fairly catastrophic when you think about both the mortality and the length of stay gains that could be made. And finally, there's a huge amount of evidence about the need to focus on discharge. In a paper based on a simulation of patient flows in A&E, which was produced by University of Warwick Medical School, they came up with 3 solutions, which again, to me, are fairly obvious, but it's worth reiterating. Consistently prioritising discharge activities significantly reduces length of stay. However, prioritising discharge activities only when a patient becomes full and goes into crisis simply doesn't work. Managers may feel heroic rushing around finding beds, but in fact it doesn't work. And it has very little impact on patient throughput or average length of stay. They also said, and crucially, that increasing beds may increase length of stay with no benefit to patient throughput. Now, I just want to pause at that point and just talk a little bit about capacity, because Simon's very right. Understanding demand capacity is all important here. But what I would say is that beds are not capacity. Capacity is clinical decision makers. It's doctors and nurses doing something to patients. It's procedures. It's tests. That's what capacity is. A bed is somewhere where patients wait for capacity to be brought to bear on them to fix them. So hospitals, and we found this in many, many areas, that get into trouble and decide to increase capacity because they're running out of beds. they will open a new ward. But what tends to happen is length of stay goes up because managing the patients through those open wards, so those new wards, is quite difficult. There are unfamiliar nursing teams, there are unfamiliar medical teams, and you can have problems. And I came across one hospital which had 200 medical beds before the winter, and midwinter they had opened up 120 additional beds, and they were no better off. Their mortality rate was increasing, length of stay was up, and they were scratching their heads about what to do. So what I would urge you to do is to understand the difference between capacity and beds when you're thinking about planning. Can these principles be applied outside hospital? Yes, of course they can. So if we think about early senior review, a study carried out in Reading found that between 20 and 30% of over 75 old, frail people's admission could be avoided if they had appropriate senior clinical decision making at the point of decision to admit, either by GPs or by hospital doctors, providing that those doctors were backed up by intermediate care resources and so on. And I think that's an important point. When we're thinking about 7-day working, when we're thinking about increasing consultant input, they can't do this on their own. It's a bit like asking the conductor of an orchestra to also play all the instruments simultaneously. It's absolutely vital that we think holistically about all the facilities that people require. So to sum up, current performance problems do arise from many factors. It's not simple. However, we really are not helpless. There's an awful lot that we can do. We need to apply known good practice systematically and also reduce variation. But we also need to understand the complex trends and the impact of small effects so we don't contribute to the problems that we are facing, and that's to achieve sustainable improvement. And thanks very much, everybody, for listening.